GI tract defects. Leaks and perforations and fistulas, oh my, are really a fact of life for anybody who does GI tract surgery, right? I mean, no matter how good of a surgeon you are, if you're operating on the intestinal tract, you're going to have somebody who has one of these problems post-op. You know, fortunately, the rates are overall low, but these are a dreaded complication if you're a surgeon. Just to highlight some things, you know, my partners do all of the weight loss surgeries, and we know that gastric bypasses and sleeves both have a leak rate of around 2%, even in the best of hands. These are obviously a source of both patient and surgeon dissatisfaction, and we know that the morbidity and the mortality of these problems can be quite high. And I think the thing is, for any one surgeon, these rates are low, but as a person who has kind of hung a sign outside his clinic that said, you know, send me your leaks and fistulas, I promise you that these things happen a lot once you kind of tally up your local hospital plus your local regional hospital plus become a tertiary referral center. I presently manage about 1.5 leaks a week, you know, in my practice on a regular basis. In the US, we know that these are a source of medical legal claims as well. This review from SWORD looked at 100 consecutive bariatric lawsuits, and the most common reason for litigation was a leak in 53%, and then an abscess, which is, I mean, a leak by any other name still smells like streptococcus, right? So an abscess and a leak are essentially the same thing. And then you've got some other rates of organ injuries that are thrown in there. Some of the problems that we face when we're talking about leaks are that the classification systems, and here I'm showing you a classification system that was proposed by Raoul Rosenthal for sleeve leaks, is that these time frames, looking at acute and early and late and chronic, they're just based off of time, and they don't really tell you a whole lot about the patient themselves. You know, most papers really describe based on chronicity, as I said. People really don't give consideration to the amount of contamination or to the shape and configuration of the sleeve, for example, if it's a sleeve leak. If you look at the literature, most of these problems are managed by groups that only perform one specific type of therapy, right? So the group may publish their stent sleeve leak management or their endoluminal vacuum therapy management. But there is really not a lot of literature that looks at, you know, let's look at the leak itself and look at all of the tools that we have in our toolbox and figure out what's the right answer for the right problem, not what do we do most commonly. And I think the biggest issue with all of the literature on leaks and fistulas is that we know that with best medical therapy, many of these leaks and many fistulas would eventually resolve. And so the question ultimately becomes, you know, what is the actual contribution of the endoscopy to the management, and what is, you know, the thing that would have eventually happened? And there's really no way to tease those things out from one another, but I think it's at least worth mentioning as a true drawback of all of the studies on full thickness GI tract management. So why do we like endoscopic complication management? And I talk about managing complications, not just leaks, with an endoscope. I think the biggest issue is that it does avoid repeat surgical intervention, but still achieve the goals that a surgery would have implemented, right? What I hope to show you is that the procedures that I offer patients are really just surgery done with a flexible endoscopic platform. For many regulatory bodies, doing endoscopy is not considered a surgery. And so if I manage a sleeve leak, for example, endoscopically, even if I do it in an operating room, it's not considered a repeat operation. And so that means that our rates of reoperation can actually look maybe a little lower than they actually are. Most patients, if you ask them, don't want more surgery. They would like something that is, you know, peroral, transrectal, that is non-invasive. I think the biggest disadvantages of doing this are that many surgeons simply lack the skill set and knowledge of the tool set, the tools that are out there to do these themselves. And I think we wind up relying on our GI colleagues who do endoscopy more regularly. The problem is that many of those GI physicians are really not interested in co-managing or taking on these complex patients. They are time consuming, they have complex anatomy, and they are litigious, as we saw in earlier slides. And so I think that when you put all of those together, we wind up in kind of a vacuum where there's not really, you know, at many hospitals, a person who is the go-to person to do this type of therapy. Endoscopic management of GI tract defects initially arose in the late 1990s. What we see is in the Japanese and Korean literature where EMRs and ESDs were first being performed, some unintended full thickness defects being managed with clip closure. That's really where the first notations came from. In 2007, as natural orifice surgery is kind of brought to the forefront of endoscopy, what we see is people intentionally making holes in the GI tract and then needing endoscopic tools and endoscopic methods to close those defects. And so, I like this slide. It's one that I use pretty commonly to show that, at some point, endoscopy became so invasive that it actually collided with laparoscopic surgery. And, this slide initially said natural orifice surgery was kind of where they collided. But I think ultimately we all understand that endoluminal surgery and the techniques and tools that I'm going to show you all came out of this collision between surgery and therapeutic endoscopy. So what are my goals when I'm approaching a patient who has a full thickness GI tract defect? Well, my goals, as I mentioned earlier, are ultimately to recreate the surgical paradigm, right? If my surgeon partners would do these things, then my endoscopy partners should also be doing those same things. So that includes diagnosing leaks, washing out and cleaning out abscess cavities, working on thorough drainage, debriding abscesses of dead or dying material, and that includes, for fistulas in particular, a knowledge of how to remove foreign bodies endoscopically. If there is a leak or a fistula that can be closed, we try to close it. And if we can't close it definitively, we're going to move to one of our non-definitive types of closures, which we'll talk about. Obviously, just like any other fistula management, we want to talk about alleviating distal obstructions. And then critically important is to get distal feeding access on these patients, especially if we know that their problem is going to require long-term management. So let's go through each of these kind of portions of the algorithm here and talk about the things that we do endoscopically. So first off is diagnosis. Some leaks are obvious and some leaks are not so obvious, and that's kind of the long and the short of it. We know that radiographic studies are sometimes read as equivocal. This is a CT scan slice you see here is a patient who had a sleeve, really had minimal symptoms, had a mild leukocytosis but no fever, had some abdominal pain, and this CT scan was obtained. And this scan was read by our radiologist as air fluid collection equivocal for leak because they radiographically really couldn't see a leak. They did wind up putting a percutaneous drain in it. We then took the patient to the operating room and performed an upper endoscopy. And what you're seeing here, this outline that looks like a stomach is actually not a stomach. That is the leak cavity where the gastric body used to be. The true lumen is actually this small amount of contrast right here. So there's actually a very large leak in the sleeve that extends into the left upper quadrant. In order to do some of the identification of leaks and identification of fistulas, and I made reference to some of this yesterday, you need to be very comfortable with fluoroscopy in the operating room. Some of that fluoroscopy includes injection of contrast directly through the endoscope itself. Some of that requires you to be comfortable injecting through percutaneous drains that already exist. It sometimes requires you to actually intubate a fistula tract yourself. This is a patient who has an esophagocutaneous fistula from a Boerhaave syndrome that he had almost a decade earlier, and this cavity runs down his costal margin along an old drain tract. And we've intubated that with a catheter, and we're injecting to show that the contrast actually extends up into his EG junction here and then into the body of the stomach. And then finally, you've got to know what wires and catheters and tubes you can put into fistula tracts to inject and show where these are located. This is a patient who has a very abnormal looking sleeve here. We are injecting into a staple line defect, and you'll notice that staple line defect not only goes to an abscess cavity here outside the sleeve, but it actually eventually makes it into the patient's transverse colon. So this is a gastrocolic fistula as a consequence of a sleeve. Ultimately, what I do at the end of the diagnostic portion of the procedure is I just take a quick pause and I draw out what the patient's anatomy looks like. This is a patient who has multiple complex fistulas, multiple areas of things that need to be reconstructed. You have probably all seen endoscopy reports on patients that just don't make a whole lot of sense because they're generated by some automated computer program. I find those to be extremely unhelpful and in fact counterproductive. And so sometimes just drawing these things out and stick them in a chart, any GI tract surgeon, any bariatric surgeon looking at this can say, okay, I understand the anatomy, here's what we got to do. And so we draw this out, and then we take a time out and we say, what are the things endoscopically that we can offer this patient as we proceed forward with the therapy? So the next thing we try and do is wash out abscess cavities. And again, you've got to be very comfortable taking an endoscope outside the GI tract lumen. This is a patient who's got that leak that I showed you earlier where a drain was put in. The yellow is the leak cavity. The blue there was the true lumen. And so what we're actually doing is we're actually going out, we're taking that percutaneous drain, which is not anywhere near the leak, and we're going to endoscopically reposition this drain in a better position. This is not a spot that was accessible radiographically. We can then spend some time washing out that abscess cavity. We've put the drain in the dependent position, and now it's going to work better. Sometimes when you do this, though, you get out into the extraluminal space, and you've got to recognize when you can't fix things endoscopically as well, okay? This patient had a gastrectomy with an EJ anastomosis that has broken down. This is obviously gross peritonitis. This patient is septic, and they are about to crash. And so what we are helping our surgeons do, this is not my patient, but we're helping, is, hey, they were going to do this open because it was an open gastrectomy. And I said, guys, don't do that. We can get you laparoscopic access here. There's actually not a lot of adhesions, and I can steer you around them. So this is now natural orifice surgery guided laparoscopic washout. So this patient was washed out laparoscopically. Additional drains were handed to the endoscope, which were then dragged up directly next to the leak cavity. We then stented this patient, and he actually recovered without a need to redo his anastomosis. So once we've kind of determined that we've washed out and we've drained the patient, we then spend some time thinking about, can we actually close this patient? There are a variety of tools available for endoscopic defect closure. I'm going to focus on the two that are in the US FDA approved for full thickness closure. Realize that commonly employed endo clips, which are readily available, are not FDA approved for full thickness GI tract closure. And that has to do with the fact that they just don't really grab a lot of tissue. They mostly close the mucosa overlying defects. They absolutely have a role in closing defects, but that role is only for when I really can't get there with one of these larger devices, which is certainly a little more uncommon. There are two devices that are available on the left-hand side here. In A, you see a device called OTSC, that stands for over the scope clip, by a company called Ovesco. This device is a nitinol device that closes in a linear fashion. On the right-hand side, you see the padlock device by USGI Surgical. Again, a nitinol device that is cap-mounted. I show you these to help you have an understanding that these devices mount on the end of the endoscope. They do increase the outer diameter a good bit, and they also increase the length of the scope somewhat. And so you've got to be comfortable navigating these things into position with a large, somewhat rigid cap on the end. The clips look different than one another, and unfortunately this is backwards from the last slide. This is the padlock device here, which closes in a stellate fashion toward the middle. This is the OTSC clip, which closes in a curvilinear fashion. This is the one that I use the most often, and I think the biggest drawback of this device is this curvilinear shape. You've really got to have the defect centered on the clip, and when people have a re-leak, the area where they re-leak is generally on the corner here where the clip is not flush with the wall of the GI tract, and some tissue can kind of squirt out of this little section right here. So you have to be aware of that. One of the reasons why I use the OTSC device more often is A, it was the first one to the market, and B, it has these really nice accessory devices that come along with it. This is a device called the twin grasper, which opens on both the right and the left-hand side. And for a defect that was just created, for example, a colonoscopic perforation where the edges are fresh, you can actually use that grasper to grab the right and the left-hand wall, draw them back together, and pull them into the cap. For tissues that are more woody or fibrotic, we have this device called the anchor grasper, which can go into a fistula tract. It deploys almost like a grappling hook and allows you to pull more woody and more fibrotic tissue in. So these graspers allow for better tissue acquisition. I think the biggest advantage to the OTSC device is that it has a tool that is designed to fracture the device to permit removal. This device is a direct current cutting device that charges with a very big capacitor. And essentially, it's a type of arc welding that superheats the metal and allows you to break the jaws on both sides and then extract the right and the left-hand sides of the device individually. that's a big advantage, because in the event that you fail, or in the event that a patient ultimately needs a surgical intervention, these devices are large enough that they will absolutely cause a stapler, a laparoscopic or open surgical stapler, to deploy and malfire. And so you have to get these out of the way ahead of time. How do they work? This is a patient who has a sleeve leak from an NG tube. What we're seeing here is an OTSC device being deployed over the top. So this is the clip that's been deployed over this area of staple line perforation from an NG tube. I apologize, this video is working a little jumpy right now. You can get really creative with how you use these devices. This is a patient who has a pharyngeo-cutaneous fistula. So what you're actually seeing is a thigh flap that has been anastomosed to the distal esophagus. Here's the thigh flap. Here's the esophagus going distal, and we can actually see a GI tract defect there. Now, just like any other fistula that may be epithelialized, we want to spend some time and de-epithelialize the tract. So here we're using a device with argon plasma coagulation to do that. Here is the de-epithelialized fistula tract. So we're going to deploy this clip on a thigh flap here, and on the distal end on the esophagus here, which is just above the level of the cricopharyngeus. You can see us applying aggressive suction, and you can see the clip has been fired over top of that defect. On the other side here, this is a colovaginal fistula. This is actually endoscopy in the vagina with a flexible gastroscope, and we're actually looking at the apex of the vagina, and you can see two areas of opening. This patient had actually had one fistula taken down surgically. This is not the fistula tract here, but on the opposite side, this area right here is a patent fistula. What we're going to do to allow this to be identified is actually pass a wire into the fistula tract, and then we're going to go into the colon, and we're going to basically just find that wire. It makes it very easy to identify the colon opening of this fistula tract. In this particular patient, that fistula opening was in a little side branch of a colorectal anastomosis. Once we grab that wire, we can then go back into the colon, and we can actually fire the clip over the wire. So we have a pretty good experience here with closing clip defects utilizing these OTSC, or over the scope clips. Our recently published series just came out in surgical endoscopy earlier this year, and we had 92 patients with 117 full thickness defects. We excluded any patient who had an acute defect, meaning if this was a perforation in a gastroscopy, or a perforation in a colonoscopy, and it was closed immediately, we took those patients off the table because they have a very high rate of closure. We were looking at patients who had fistulas and leaks that presented in a delayed fashion. We also very strictly defined success as we went in, we closed the defect, it was successful, and no long-term management was necessary. So overall, our defect closure rate at 5.5 months was 66%. You can look at this as, yeah, you failed a whole lot, or you could look at it as you avoided surgery in a lot of patients. The defects were obviously different. For patients who had fistulas, we had about a 55% success rate. For leaks, about an 80% success rate. One of the things that I like to highlight when we talk about this is that no patients required an emergency surgery. So these were patients who were clinically stable, who we took to endoscopy, and after our interventions, nobody still required surgery. And ultimately, if you look at patients who did need a surgical intervention, only about 15% of patients ultimately got a surgery. What that means is that many patients were sent to us with a leak or a fistula who had already been deemed a non-surgical candidate for the management of this problem because they were too old or too sick or had other stuff going on. It also means that some patients in whom we said our closure was not successful, the endoscopic interventions that we did, coupled with best medical therapy, allowed a lot of those defects and fistulas to ultimately close. And so the adjunct that endoscopy added to the comprehensive management plan may have ultimately been successful. We just couldn't say that the things that we did were the primary reason for the closure necessarily. What if you can't endoscopically close something with a clip? Well, there are now two commercially available suturing devices, both made by the same company. One is designed to fit on a very specific Olympus endoscope. The other is now redesigned with the same suturing capabilities to go on any diagnostic endoscope. The patient you see here is a patient who had a gastrojejunal anastomotic perforation from a large ulcer that was already taken to the operating room and managed surgically, and she re-leaked. We took this patient to the operating room and we essentially endoscopically closed the corner of the ulcer. You see a sewing here with a Prolene suture. We then dropped the suture as a T-anchor in place and we cinched this down. This patient already had a drain on the contralateral side that we repositioned. We already washed the cavity out. So I'm not showing you those adjuncts, but there we see the defect fully closed, and this patient ultimately made a good recovery. We also placed at the end of this procedure a nasojejunal feeding tube downstream from the area of perforation. What if closure is not possible? You know, some defects are too large to close, and so we don't try to close those. Endoscopic stents are probably the thing that most people are familiar with for the management of defects. I do want to emphasize that there is no commercially available stent that is approved for the closure or management of a leak. This is not what they're used for at all. And so when I talk with patients about using stents to kind of cover a leak, I tell them a few things. Number one, this is not definitive. We're going to put this thing in place. It's going to allow some of the effluent to go into the stent and bypass the leak. But these, just like vascular grafts can have endoleak, these things have a lot of endoleak around them. And they are part of a medical management strategy, which includes NPO status or distal feeding, drain placement, and antibiotics. But they do have utility, especially for leaks that are really challenging to reach endoscopically. Here we see a patient who's got a large enteroatmospheric fistula that at some point will become an enterocutaneous fistula from a previous GI tract complication. Here you see a stent that has been deployed inside the fistula tract itself. This is what it looks like radiographically when you get an X-ray of it. This is a well-positioned stent. It's in a nice straight line, which these stents all like to be in. And if you get this in a nice position, you can actually have it granulate in place. This is now an enterocutaneous fistula several weeks later. And now we get a swallow study that actually shows there's no leak, there's no fistula. The stent is unfortunately orphaned in situ and it is not meant to be there, but this patient has a large abdominal wall hernia. They're ultimately going to go to the operating room to get their hernia managed. And at that time, the portion of the bowel where the fistula used to be is simply resected. The stent is removed. As I said earlier, we know that these stents don't occlude leaks and fistulas entirely. This is our initial experience with using stents for sleeve leaks. And what we found is that almost all of these patients had leak around the stent or migration. And so these do require a little bit of therapy. But when you put them in, for example, for an enteroatmospheric fistula, you can see that number one, the fistula output drops dramatically in almost all patients. So you really can control a fistula a little better with these things. In our series that we presented at SAGES in 2014, 2 of our patients were totally off TPN, 2 were on partial TPN and partial enteral nutrition PO, 2 still required full TPN, but again, had lower amounts coming out. And so the TPN management was a lot easier. And we also know that outside the US, there are now a lot of commercially available stents that are designed specifically for sleeve leaks with shapes and configurations that are meant to help hold these things in place and keep them from migrating distally. I still use stents occasionally. This is a patient who several years ago had a very large sleeve leak. You can actually see radiographically the large gap here in the staple line in this extraluminal abscess cavity. When we inject contrast, you can see the amount of contrast leaking out, but I want to point out this is after the stent is already in place. So even when you put a stent in place and it's well positioned, these do have endoleak. But if you give it enough time, these things will eventually scar into position. You can see there's now no further leak. You can see a previously placed surgical JP drain here, which is now essentially a G-tube. And so we'll pull that foreign body out of position. We'll continue with our distal feeding access here, and this patient will eventually get better. I think the second place where stents have very good utility is something like this. This is a essentially complete anastomotic disruption following an EJ anastomosis for a gastrectomy for cancer. The anastomosis is 100% disrupted. The ends are very difficult to find, but if you get lucky and you kind of navigate your way around a little bit here, you can eventually find your way into the distal lumen of the small bowel. Takes a little bit of patience and a little bit of persistence. But if you get into the distal lumen, what you can now do is deploy a stent to reconnect the esophagus and the jejunum. And what that essentially does with good extraluminal drainage is give a construct about which the body can granulate around the stent and reform an anastomosis. They like to stricture down after the stent is removed, and they do require dilation. But again, it's an appropriate management strategy. If you have to redo that anastomosis, I'd rather redo it down the road for a chronic stricture than I would acutely for a leak like this. When we can't manage leaks with external drainage, we now move to internal drainage with double pigtail catheters. I'm going to show you a video here, but I wanted to emphasize the point that you've got to be comfortable utilizing multiple different types of endoscopes. This is our standard diagnostic scope here, which we use to get in. They are a nice size. They've got really good visualization to allow you to visualize most leaks. And that is the scope that you see us using here with a distal cap attachment to allow us to push tissue out of the way. If you want to investigate and go through a lot of abscess cavities, you've seen me show several video pictures of us using this ultra slim 4.9 millimeter scope. I will use scopes that are even smaller than this nowadays. I use ureteroscopes and choledocoscopes to pass down fistula tracts as well. This is the double channel scope that you've seen me use several times with the sewing machine or with clips on the end of it. This is nice because it's big enough that you can attach those devices. The downside is the scope is very large and can't reach most places in the GI tract. So we will switch scopes several times during the procedure. What you're seeing in the video now is a patient who has a sleeve leak. This is a patient who has actually failed an attempt at an Ovesco closure. So you'll see an Ovesco clip here in the corner as we're working, but there's still a leak cavity and the patient still has ongoing symptoms. And what we're doing is using an endoscopic grasper to identify an area fluoroscopically where we think the leak is located. You can see the pus that comes out of the leak cavity. We've now switched our scope and we're using this ultra slim scope here. This is the patient that I showed you earlier who has a gastrocolic fistula. And so part of the reason why this patient was still leaking persistently is that there was a fistula on the colon side. And so what we wound up doing in this case was we place a wire into the abscess cavity, and we're going to exchange our scope out to a much larger caliber endoscope that will allow us to pass a 10 French stent into this cavity. So we're exchanging a scope over the wire, and we're going to deploy a stent that will allow internal drainage. After we finished this, we then prepped this patient for a colonoscopy and brought her back subsequently for a closure of the colon defect side of this as well. So here you see us deploying a stent. This is a double pigtail stent. So one end of that pigtail goes into the cavity. The other end will go into the lumen, and that will allow for internal drainage of this cavity. There you see the Ovesco clip that we previously placed. Again, the reason for failure here was not specifically the over the scope clip, but rather the fact that we didn't recognize early on in this patient that there was a fistula on the contralateral side of this abscess cavity. So here you see that being deployed. There's the double pigtail with one end inside the abscess cavity and one end inside the lumen. There's a variety of other stents that you can use. Again, these are mostly meant for biliary purposes, but we do use them quite regularly for internal drainage. You can do combination therapy as well. That includes things like placing double pigtail stents to drain the abscess cavity and then placing a luminal stent to cover it, as we showed earlier. The other option is to actually do an endoscopic septotomy. This is a video from my junior partner, Josh Winder. This is a patient who had a sleeve leak converted to a gastric bypass where they never really managed the leak, unfortunately. And so there's still this very unusual extraluminal pocket. You can see the guide wire in the extraluminal pocket. The true lumen is on the superior portion of the screen here. What Dr. Winder is doing is actually using an endoscopic cautery tool called a triangle tip knife, which we commonly use for palm procedures and other EMR and ESD procedures. And he's essentially dividing the septum between the extraluminal pocket and the true lumen of this patient. And at the conclusion of the video here, what you'll see is this entire septum is gone. He makes it all the way through this. Here's the last little portion of it right here. And you can see these two cavities becoming one. This patient had severe dysphagia, primarily because the extraluminal pocket was about 3 times as large as the true lumen. And so once these are coupled back together, she's going to have an adequate pouch here for digestion, and her symptoms completely resolved once that procedure was done. I'm going to conclude by talking about endoluminal vacuum therapy here, which is kind of the newest kid on the block. This has been used in Europe for some period of time. Stephen Leeds from Baylor probably deserves the credit for popularizing this and being a very early adopter in the United States and North America. His initial series of 53 patients had 15 patients after Roux-en-Y bypass, 15 after sleeve. And the bottom line here is what you do is you take a nasogastric tube and you endoscopically suture black granufoam from an standard endoluminal vacuum to this. There's two sutures. There's a 2O-proline here that goes through and through and then is tied in a suture ligature. And there's another 2O-proline at the end here that goes through and through and is used as a handle to drag this into position. What Steve showed is that even in big leak cavities that are heavily contaminated, they had an 83% closure rate without the development of long-term fistulas and without the need for surgery. The downside to this therapy is that the vacuum is changed somewhere between once and twice a week, depending on who's doing it. And bariatric patients required an average of 10 changes. And so these patients spend a lot of time in the hospital. If you look 55.3 days of therapy, this is very labor intensive, but at the end of the day, the ability to avoid another surgery down the road and the ability to salvage your bariatric procedure without long-term complications is really a noble goal. And I think that it's probably worth the intensivity of the therapy. Here are some of our own examples. This is what we would call essentially a more simple endoluminal vacuum therapy. This patient had a D2 gastrectomy with a hand-sewn anastomosis. And fluoroscopically, when they do a swallow study here, there's a leak. So when we perform endoscopy on this patient, we want to start by identifying the leak cavity. And the first question we have when we scope a patient like this is, again, can we close this leak? And so that's the first thing that we're looking for. So we'll go in endoscopically and we'll spend some time identifying what the leak looks like. If we had the option to simply place a clip on this to endoscopically suture it, that would have been our first go-to method. This patient does have a drain nearby, as well as you saw highlighted there in the CT scan. Unfortunately, when we get out into the lumen of this patient, what we see is a very heavily contaminated cavity. There's a lot of fibrinous debris. There is a subtotal disruption of the anastomosis. If you look, the bottom corner here is still intact, but everything else circumferentially, this is about a 75% disruption. Before endoluminal vacuum therapy came about, this is a patient who I very likely would have endoscopically stented. That would have certainly covered the area of leak, but not allowed for the debridement of the tissue that we think is necessary. So there's the anastomosis. It's about a 300-degree disruption. You can see all of the silk sutures that were placed there. Those silk sutures will eventually become a nidus for ongoing infection and persistence of the leak. And so as the therapy progresses here and days and weeks go by, we will spend additional time using endoscopic sutures to cut those out. Again, what we'll essentially do is take our black granufoam, we've created it outside the patient, and we are dragging it into position and putting it in the extraluminal pocket to the side of the anastomosis. We put this on suction. This patient did have distal feeding access already, so that was very helpful. It allowed us to essentially give them jejunal rate feeds. If patients don't already have feeding access, we put them on TPN, and the reason we do that is, as much as I dislike TPN, they go back to the operating room so many times that the TPN is on and off and on and off and on and off, and we don't like that. So you can see the previously placed extraluminal drain. You can see granulation tissue starting to form here around this. This already looks a bit cleaner. What we will eventually do is we'll debride the cavity here with a cap, but we'll eventually pull that drain back as well. We do not want to form a fistula. And so disconnecting extraluminal drains from the lumen is a goal that we strive towards as well. Again, as we just kind of fast forward in time here, we see ongoing therapy, we see additional granulation tissue forming. We'll continue the therapy forward. And this patient eventually made a full recovery after about a month and a half of endoluminal vacuum therapy. On our last sessions here, you can see that the anastomosis is regranulated in place. This patient is now almost 2 years out from his initial therapy. And what you see here is a swallow study and CT scan showing no leak, no complications, and fortunately for him, no recurrence of his cancer either. Now, EVAC therapy can get a lot more complex. This is a patient who had a sleeve leak. This patient had a bleed immediately post-op, was taken back to the operating room. It couldn't be managed laparoscopically. It was converted to open. And ultimately, they've had about an 8-centimeter breakdown of the staple line. You saw some of the staple line reinforcement there. We wanted to debride that again. This is just collagen and nonsense that's going to feed the abscess cavity. So we will debride all of the staple line reinforcement out. This patient actually had a huge amount of contamination of the midline wound as well. And what you see us actually doing here is navigating our way from the sleeve leak and out through the midline wound. You might think that this is bad, but we actually like this a lot, because the clinical implication of this is that we can actually perform endoluminal vacuum therapy, both prograde and retrograde. My ultimate goal in patients who have a leak is that they do not develop a chronic fistula. We want the leak cavity to be managed internally. And so what we actually did in this patient, and we presented this at SAGES just earlier this year, along with some papers from Eleanor Fung at Buffalo, who has also done this type of therapy, is we basically put a vac on the outside and a vac on the inside. And we slowly pull them apart from one another and allow the leak cavity to not form a fistula tract, but to granulate from the midsection out to the wound, and from the midsection internally into the lumen itself. So again, you can see the amount of contamination isn't so bad here. This patient actually had an area that wasn't being very well drained. There was a retrogastric abscess. And so again, we took the opportunity to use that midline wound to actually place a percutaneous drain. Here we're grabbing a 19-round Blake drain. We're pulling it into the midline wound. We're going to park that directly in the lesser sac, directly in the retrogastric abscess. And then we're going to continue our EVAC therapy on the midline portion of the wound. I won't really bore you with the rest of the video, because all it really is a bunch of vac dressing changes over the course of time. But you can see that this abscess cavity is getting smaller and smaller. It's becoming increasingly more granulated. It's draining internally. And at the end of the day, this is this patient's swallow study. After we stopped the EVAC therapy, we placed a nasojejunal feeding tube on her. This is about 2 months of therapy. She's got a normal swallow study. She has no dysphagia, and she ultimately has done well. I mentioned very briefly alleviation of distal obstruction. Lots of things to think about. Strictures, physiologic sphincters like the pylorus, which you see us Botoxing and balloon dilating here. This is just standard endoscopic therapy with CRE dilators. I've also mentioned a few times distal feeding access. Again, we get very creative with feeding access. Here you see us placing feeding access through a stent over a wire. In patients with altered surgical anatomy, we'll do a PEG, as you see here, in a patient who's got a post-bypass leak. A PEG is a really great option because it's downstream from all of the nonsense that's going on. It doesn't require you to re-surgically access the remnant, which is sometimes not accessible. I think the paradigm that I try to emphasize here is that GI bleeding, we know, is best managed with multimodal therapy. And I ultimately think that leaks are probably the same. I think you get the highest rate of success if you do multiple therapies that I've shown you here. For example, drainage plus closure plus distal feeding is probably a lot better than just going in and putting a clip on something. And the problem is, it's very easy to put a clip on something. It's not so easy to go in and do all of these things comprehensively. In our series of Ovesco closures that I showed you earlier, the vast majority of our patients had some additional therapy in addition to the clip placement. You also have to be prepared to do rescue therapy. You want to plan stage interventions and think about step 1, step 2, step 3 for these patients moving down the road. In the interest of time, I'm going to skip this last video, which kind of puts all of those things together, and just conclude by saying that endoscopic management GI tract defect depends on surgical knowledge. These are all surgical maneuvers that you saw me do, but it's heavily dependent on good endoscopic skills. I think one of the biggest impediments to surgeons doing this is that you might not be aware of all of the tools that are available to assist you. And so learning about the tools that are out there is very helpful. For leaks and fistulas, the highest rate of closure requires multimodal therapy and repeat interventions. But we as surgeons are uniquely suited to manage these problems. We cause the problems, we see the patients, we have a relationship with the patients. but ultimately we have to be capable of offering these therapies to maximize success rates. With that, I'll conclude. As I said yesterday, if you have questions, issues, if you've got patients you want to run by me, please feel free to email me, send me a message. I will happily answer, to the best of my knowledge, what I can about the patients that you're presenting to me. I'd be delighted to hear from you. Thank you.
Thank you so much. That is amazing stuff. And I, you know, I remember the when we started with notes like forever ago, when I was in my fellowship, and we thought, we didn't know how this was going to sort of end up. And I think, like you said, I think this is sort of where it's really landing, like endoluminal surgery. And you're a real pioneer in this field. So thank you for sharing all this great work with us. Does anybody have any questions? I don't see anything in the chat. Fantastic and inspirational, says Jerry. It's pretty cool coming from Jerry Free.
Thank you. Yeah, honestly, that means a whole lot. Again, you know, you're right. I mean, I spent my lab time working on notes procedures. I learned a lot of the endoscopic maneuvers that I know from our GI providers who were doing research along with me. I then spent time with Jeff Ponsky and Jeff Marks and took those skills and kind of the knowledge that, you know what, holes in the GI tract, I mean, we can make them and we can close them. So, you know, why can't we manage them? Why can't we manage them this way? And I also quickly learned, I mean, the defects that we were managing earlier were very simple. These were totally stable patients with small leaks. And inch by inch by inch, you kind of get to the point where I'm showing you an endoluminal vacuum patient who has a subtotal disruption of a sleeve, you know, who's actually quite septic and quite sick. And my partners will call me and say, hey, this one's kind of on the upper end. Can you do this? And the answer is, yeah, we're going to try, because we understand that if we genuinely can't do it, we're going to tell you we can't do it. But the numbers that we can't do are becoming increasingly smaller as time goes on.
As you gain more experience. We do have a question actually in the chat, and I'm sorry that I missed it because it came earlier on. Have you had experience with esophageal airway fistula?
Yes. So I'm going to stop sharing here so I can kind of go full screen and chat. So yeah, so we have done a number of TE fistulas, including fistulas in children, and we've presented some of those. We have a 14-year-old or so who had a recurrent TE fistula that was obviously fixed as a neonate. We tried multiple times to close his fistula endoscopically. We were ultimately unsuccessful in doing it. But you know, one of his goals was he was coughing a lot. He couldn't tolerate the PO, and he was a football player, and he wanted to finish his freshman year of football season without having to like not play. And so by clipping him, he had enough symptom relief that we actually managed to get him through the football season. And then in the summertime, he got his surgery, and then he went back in the fall and played football. So, you know, in that particular case, while we weren't successful in the way that we wanted to be successful and avoid a surgery, he was really stoked that we could simply put a clip on this thing. And even though it kept falling off and he had recurrent symptoms, we managed to get him through the football season. We've had several other TE fistulas from surgical misadventures, let's call them, that were able to be managed surgically, that were able to be managed endoscopically. One of the EVAC patients that I didn't show is a patient who had a near complete disruption of a esophagogastric anastomosis following esophagectomy, who took about 90 days of endoluminal vacuum therapy, including management of a fistula to the apex of his right lung. So we've done some fistulas, not necessarily to the major branches of the airway, but to actually lung parenchyma itself.
Do you want to comment, anyone there in the thoracic surgery group?
Yeah, so I think we provide a lot of the fistulas to our institution.
It's very kind of you to do. As a recipient of fistulas, I appreciate it. Thank you.
Yeah, so they're not in the best shape to travel down to Penn State, but I would say the evolution, just as a comment that we've gone through, is really, so we started stenting probably in 2005. When I started coming back, we started stenting, and then we had a lot of fistulas from the stents. A lot of complications. You mentioned there a little bit about the the rigidity, how the stents want to be straight, and placement is extremely vital because they end up perforating in both areas of the edges. So it caused more problems than they do. So we moved away from them for a while, and we went into VAC. The VAC dressing. A lot of our European colleagues have switched to VAC completely. And now we're sort of do maybe 20% VAC, 80% stents, but very close. I think what I've learned over the years is VAC is probably very good to place, but very good for the patient, but very bad for the surgeon. It is extremely onerous to place and to replace. We can no longer. I have not been able to do it under local sedation. I have to end up having to do it under general anesthesia.
Agree.
And so that's why we've gone back to stenting quite a bit. But I can say with stents, you have to maintain them really closely. So no one gets more than 4 weeks of stented. We take it out. If you still have a hole, we may try something else, or we go back in and place a stent again. But we maintain them really closely, or else they end up eroding into things.
I agree, and that's that is one of the clear disadvantages of stents. There are a lot of complications, and if you're not, if you think that you're placing the stent and then you'll just come back 12 weeks later and things are going to be better, that's just not how you get the best success rate. What I appreciate about your comments though is that what you are doing is looking at the leak or the fistula that you have and applying to the best of your knowledge the therapy that you think best matches the leak. And I think that is probably where the best success rates are going to come from. If you look at something and you say, in my experience, this is better for EVAC, then it probably is. If you think a stent is going to work, then it probably is. And the ability to switch between different therapies as you see the progress is where the best success rates are going to come.
I would love to continue this conversation, but we're out of time and people have to run to the OR and off to their clinics and so on. So I want to thank you, Dr. Pauli, for an amazing few hours yesterday and this morning for just an excellent talk. It was great having you as our visiting professor. We would have loved to host you in person. And when all of this is over, we'll hopefully invite you over to visit Montreal.
I'd be delighted.
Try some Quebec cheeses.
Perfect.
Quebec wine is not very good, but maybe we'll have.
If you think we have Pennsylvania wine, we can do a blind taste test and see which is not so good.
Take good care. Thank you very much.
Thanks, guys. Appreciate it. Great to see everybody. Bye.